Chapter 1, the phlebotomist. And we're going to talk about job duties and responsibilities. Chapter 1. The primary duty, again, tissue samples of the fluids by venipuncture most of the time. Vena meaning vein, puncture. That's what you're doing. Blood samples will be used in blood collections or donations, transfusions, research. Most of the time it's to see if everybody's healthy. Your blood work tells everything about you. It will tell so much. And you have to get the blood work right. You have to treat the blood right. You don't want to shake it. You don't want to drop it. You want to do all that because it breaks up cells and changes what is the reading in your lab work. So if you ever drop one, you need to pull it again because things bust when you drop and shake too much. That's why you do not shake it. You invert it. You don't shake up the blood. You know, all of those tubes have a little anticoagulant in it or not. But if it has anticoagulant, if there's something in that tube, you're going to mix it like this, not like this. Because you can break up the blood cells and it causes the readings, your lab values, to be different. So you don't want to break up stuff. Underline this, and to say this, a lot of the first paragraphs in each of these chapters have so much information in them. If you get that down pat, you will be on your way to success. And that's even with CMA. Those first paragraphs in each of those, they pack a lot of stuff. It's weird that they kind of go from subject to subject real quick, like. But those first paragraphs, very important. Lots of information and lots of test questions come from. So underline that. A type and cross-match process takes place for transfusions to determine if a patient will react after a transfusion. So what do we do to make sure they won't react to a transfusion? What kind of test? Cross-match. Type and cross-match. If the process of collecting a specimen for further laboratory testing, such as clinicals, pathology, I don't know where I was going with that, but underline this. Anatomic pathology focuses on testing specimens such as biopsy. So they stuck that right on in there, and they're just really trying to talk about where you can work at. But anatomic pathology focuses on testing things such as biopsy. So where would you send a biopsy tissue to? Anatomic pathology. Okay. Also, they like to, and you'll see this in your chapters and your readings on chapter 1, they're going to put you in a category. We, as phlebotomists, we are gathering up the information. We are gathering the sample. So we are called pre-analytical. Underline that. The phase for phlebotomy is pre-analytical. We send it to the doctor and they analyze it. We don't analyze it. Pre-analytical is the phase of phlebotomy that we are in. Pre-analytical. So underline that word as well. That next sentence as well. Neonatology. What is that? Dealing with patients that are newborns that are a few hours to a few days old. Underline that. You see that kind of jumping around, telling you all kind of stuff, but they're doing that for a reason. They're letting you know that this is some important stuff. A lot of test questions come from your first paragraph. The next one as well. If blood is collected for testing drug levels, the primary consultant for timing guidelines is the pharmacy or pharmacy department. So what they're trying to say, if there is a timed drug specimen that we're going to take, is up to the pharmacy is going to be the one that says the say so, because they're also the ones that are making sure what times you're taking your medications. You're taking them at 8, 4, and 8. So we have to have a lab drawn right before the next dose. Most of your drug levels are going to be right before the next dose. You're going to go and pull their blood to see what the drug level is in their blood. So we need the lowest that it's going to be right before they take their next dose. So we're going to come before med pass, which is 4 o'clock. So we're going to be there at 3 o'clock, 3:30, and making sure we're getting the lowest level that it's going to be. We need to know those kind of things to know, say it's a diabetic, not a diabetic, but a seizure patient. Seizure patient, that's number one. If their medications are not at a certain level, then they're going to have a seizure. So we're going to make sure that that medication is therapeutic, and so we got to pull it. So say it needs to be like Dilan needs to be 10 to 20. And say it's right before they take their next dose and they don't drop to an 8 level. So that means the doctor's going to look at those labs and say, they only have an 8 level of dilatant in the blood, we're going to change the medication. And that's why all this is important. The medications are being changed for that. Things are being ordered because of blood work and their labs that they're showing. Oh, and a doctor will, diagnose. They're like, okay, that's what's wrong with them, because they finally got the blood work and they're like, oh, okay, we can fix this. So blood work is very important. What they're stressing here is drug levels would be done, or the consultant for that would be your pharmacy, because of medications. You want to take those take their blood right before the next dose. So if they've already taken the next dose, what are you going to do? Skip that patient and go to and figure out when their next dose is. But if they've already taken their medication, that's not going to work, because we're already going to know that once they take their medication, it jumps on up. And it's going to be therapeutic for a while. But we need to know how low it goes down so we can keep that at a certain level. And that's what the doctors are going to be there for. They're going to say, okay, that's lower, let's add 50 milligrams. So to keep them at that level. So those are very, very important. Next one, therapeutic phlebotomy. Underline that. It's removal of a large amount of blood used to treat hemochromatosis, porphyria torta, and polycythemia. Excuse me. So underline that, and no, question might be, why would we use therapeutic phlebotomy? A, B, C, D. And one of them would be hemochromatosis. One of them would be, or the other three wouldn't be. So make sure you know why and what diseases that we're going to use that therapeutic phlebotomy on. Hemochromatosis, porphyria torta, and polycythemia. And we'll kind of put those words together in a minute, but a lot of times it's just meaning that iron is the hemochromatosis. You got too much iron going on. Polycythemia, too many red blood cells, so they will pull. Therapeutic phlebotomy just means it's like back in the old days when they drained your blood, but now we still draining blood like they did back in the days, but there's a rhyme and a reason to it now. It used to be they just drained your blood and you died. You didn't get no other blood. But just know those as well. Know that the pharmacy needs to know how to communicate well, or phlebotomy, sorry. You need basic knowledge of the healthcare system. Always follow discretion, confidentiality. HIPAA never goes away. Do y'all know what HIPAA is?
Private.
Keep everything private. HIPAA stands for Health Information Private, Portable, Private, Health Information, Portability. I have forgotten what it stands for. Don't tell anybody.
Private for the health, like don't tell like the medication and all this stuff like that.
Yes.
Even tell if you see a patient,
Right. You can talk and tell everybody any day what you've done. Do not add names to it. Don't give hints, because I've seen that too. Because I've actually worked in an HIV clinic. Now I really wanted to tell somebody, but later on down the road I realized she had it too. But they might have met there. I don't know. But and one of them was my really good friend, and I say was because she's passed. But and I wanted to tell her about the fella. I've seen it, and then find out he had it too. I think I always messed with him. I said, and I never acknowledged that I knew really, really. But I was like, I don't know how they all meet together. What do y'all go to the clinic and say, well, you got it, I got it too. We good together. But that is not true. And always, you may have a different strand of HIV than I got. If I get yours, I'm gone. If I keep mine by myself, you keep yours, and maybe we can survive. We can live this last thing. But if you get a whole nother strand that is not your strand, because that's why we can't cure it, that's why we can't fix it. It could be just like the flu. It could be just like that if it didn't deviate so much. It changes and it messes up, and that's why they can't cure it. They're working on things to cure it. Even now they've got drugs that if your partner has HIV and you don't, you take preventive meds and you won't get it.
I've seen that commercial.
Mm-hmm. they've got that now. They call it a PrEP, and they call it a couple of other things, but that is, that's real.
Okay.
It's real, and it keeps you from getting it knowing that your partner has it, if you have not got it. And that's helping people nowadays. Some people, I just wish there was something that just would eradicate all that. I just hate that my young people are coming into that, but they are. And we dealt with it too, but it was more isolated and more in the male bisexual community. But it's everybody. It's everybody. And people don't know they have it and didn't mean to get it. I had this speech earlier, but don't never judge anybody. You don't know how they went out there and got it. They whatever. They broke up with their husband, been with their husband 20 years, met one guy.
And boom.
And that's it. Vice versa, I've seen a housewife knowing I just had every idea that she didn't go or do nothing, but she ain't. You know, people just put a stigma on somebody. You did, just like you have had unprotected sex, and you can't tell me you ain't because you done had children. That's how I talk to my children, my high school people. Yeah, you're not. If you got babies, you done had unprotected sex, and that was your chance that you could have got HIV. And then some people just continue. You know, say these wives, and I've seen it, done it. My man cheated on me, and I still was with him, but guess what? For 20 years, I done broke up with him now, but 20 years I wasn't, you couldn't have sex with me without a rubber. You put on a rubber, and you're not doing anything else. You just, that's it. Because I don't trust it. I know I'm a nurse, and it doesn't help me. It doesn't help that I'm a nurse, because I know it's out there, and used to you could see people, you can't no more. People are just as healthy as you and I, and but you still don't judge them. But I don't want to get it. And I just know that teenagers are out there doing it, and because they're teenagers, they're better because they're just getting started having sex. But let the years come on. They'll be in the same category. That I'm scared to death. And he tried. I was like, oh no, sorry, baby. You will not. But we just separated probably about a year ago. But for about 20 years, you was not getting nothing. Nah. Not without a protection. So we used a lot of protection. We went through that. Job test. You're going to assemble your equipment, keep track of supplies, follow safety rules, verify and record patient information. That's very important. Who are you? When's your birthday? You look to make sure that the name matches exactly what you have on your paperwork, that label, everything's got to match. Hopefully you'll have a label. Sometimes you're going to have to write it on the tube itself. Depends on where you're working at. Sometimes they'll print a label out for you and you'll be like, yes. Sometimes where I worked, it was you made your own label or you put it on the tube, a little bitty handwriting. So you're going to have to verify all that before you label a tube. You never label a tube before you draw the blood. Something might happen. You never know. You might get hurt, sick, something.
You label too before you draw blood.
Label after, always.
After.
After, always. Never before. Never, because you don't never, ever do that, even nursing. You do nothing before because that's anticipating you're going to do it correctly and nothing's going to happen to nobody, even including you. That patient may have a seizure right in front of you. And then those labels are sitting there for the next patient walks in and the next nurse uses those tubes because she thought they were hers, whatever. But things happen. If you don't send a label in, they're going to tell you, sorry, even though you only draw one person's blood today. And you know whose blood it is. They don't care. Throw that blood away and draw another one because we're not in the game of guessing that that's correct, even though you know in your heart of hearts that's whose blood it is. And it was hard to get. You still going and getting some more blood.
But you know, the new technology, you don't have to write no more because they scan.
Not in Moultrie, you have no rights.
Yeah, it really depends.
It depends. So you want it.
It really depends, and that's because it's more accurate.
Like
You're
some
gonna,
hospitals, like,
you still might identify you're a patient, but you still might have to write that on the tube, because they ain't got, how are you gonna get that onto their tube? You've got to label the tube.
yeah, but I'm just saying, like, that wristband, like.
Yeah,
in
you
the
might be able to
hospital,
do that.
And you scan it.
Yeah.
Yeah, scan it.
That
and
would be identify your patient, and you might be able to
And
do
you put
that.
you put the label on the tube.
Where's the label coming from?
Out of the computer, out of the babies. Cause somebody walk around with a computer and all
They have a
that.
little
Yeah.
print.
If they have that,
Yeah.
that's not a guarantee. That's technology, that's expensive. They may not be into that. Most of your doctor's office, most of where you're gonna work, CMA is not gonna have that. Phlebotomy in a hospital, you're probably gonna have labels.
Yeah, I see that too. It's
And make sure they don't have it yet. They working on it.
Okay.
They don't have it
Yeah,
yet.
it's trying to come. It's expensive. It's an expensive setup.
Tiff
But
Richmond
you
had
might
it.
be able to scan.
I think Tuckerville had it.
You still have to scan. What if the girl at the desk puts the labels in the wrong chart? You still are checking. There's no ifs, ands, or buts. You're checking everything, even the label that is in that chart, that is connected, that is in that whatever. You're still checking. There's no quick ways about it. You check that just like medications. You check it 3 times. You check the labels 3 times. You do not want wrong blood sent to the lab with the wrong person's name on it. And yes, they have. I've done it. I've sat there and pull the wrong labels because it's in that chart. It's with them, and labeled the blood, and it'd be the wrong person's blood. I mean, same person that's in front of me blood, but the wrong label was in her chart.
So you had to go back and redo.
Oh yeah. Cause they'll be like, well, you didn't have no blood work today, and then they'll be missing that person's blood work.
Yeah.
I'll be like, I know I draw their blood. You can't go back and go digging through tubes and figure out, well, this is her blood. You know, you can't do that. You're gonna go back and just redraw. So labeling is everything. That is legally everything. That is ethically everything. All that. So what I do, I label it and show it to them. I said, that's you? They'll be like, yeah. Oh, okay. You know, and that's my checks. This you, you know, okay. That's,
You gotta put the person's name on the receipt.
it depends on where you're working at. So all this depends, and you may have a label that has all that stuff on it. You may have a label that has a little spot for you to put the time on it. You may have a label that has their birthday, or not a label, and you have to write on the tube.
Yeah.
It really depends on where you work at. Most of your doctor's offices do not have all that special equipment. You're gonna just label,
Yeah.
and they don't even have labels. Most doctor's offices, you know, in case they're big doctor's office affiliated with somebody, but the little ones don't. They're not printing labels. They're writing on their stuff. So it depends again where you work at. Okay? That's rule number 1. Identify, label. Assist the patients before, during, and after the procedure. Disinfect your areas legally, ethically. Anytime somebody sits anywhere, you're supposed to clean that area up and then let somebody else sit there. That's what they say do. I don't see a lot of that happening. Even in the lab, you just go sit down. No, there ain't nobody disinfect that chair and clean it and everything, all that. But ask questions. That's what you do. You're cleaning up everything. You're reusing you're throwing away everything, not reusing nothing. You'll see things that you can reuse eventually. But let that be the culture of that place that you're working in. You know you've been taught everything goes away. Tourniquets are the worst. We reuse them over and over and over. You're not supposed to. Those little containers, we use them. Shouldn't do that either. But that's question. You don't reuse anything. Everything, disinfect, reuse nothing. Drawing blood, of course we're going to do that. Labeling and storing blood, reporting possible hazards. What equipment you'll need? Your work duties should be is categorized in 4 major groups: your equipment, procedure, patient care, and patient information. So your equipment, all that good stuff, you've got needles, bandages, gauzes, tubes, collection devices, labels. You may have tracking supplies that ensure proper amounts are always present. What you'll have to do, that may be, and it'll probably be you. You see this blue tubes are going down. blue tubes, y'all see the tubes. Then you need to reorder some blue tubes. Put in a requisition. We need more blue tubes. That is continuing as well. Make sure you dispose of your needles in a sharps container. For your procedure, make sure you're finding the correct site, that you're correcting the correct amount of blood, label it, and submit your documents properly. Patient care, reassure your patient. Sometimes you're gonna have to hold your patient. Sometimes, mama's holding the patient. Boyfriend, girlfriend's holding the patient. It really depends. Some people are just as scary of a needle, and it's just a little bitty prick, and it really is. Once you get up under the skin, it's gravy. You don't have as many nerve receptors. It's that first little getting in there that might hurt somebody. And a lot of people don't let that alcohol dry. If you don't let that alcohol dry, you're going to get a bigger prick anyway, because the alcohol is connected to your skin. And that's why you don't put alcohol on things.
I'm at some, you know how you go, not newborn, but they be like some mothers, they get that first shot. Who do that? Just us do this?
Normally it's the nurse. Normally it's the
nurse
nurse.
do that.
Yeah.
Okay.
CMA possibly depends on where you work, but they'll show you different specific things like that.
And drugs, right? That's why we don't do it.
Depends on a lot of times they're collecting blood samples too from newborn. But most of the time it's gonna be that nurse does all that. She gives the injection, gives the eye drops, she gives the I want to say PKU
I'm on the 4 shots
for the baby.
dies.
Yeah, that's part of them. That's gonna be your nurse most of the time, because they get it right in. If they come out, they're still, because those nurses are one-on-one with them newborns. But you may be that CMA that works in the in neonatology, and you'll be giving them. It depends. Because the nurses, if that's the case, they'll be doing all the respiration stuff. Bigger hospitals, more specialty, you'll be able to do specific things. Most of the time, this little sort of South Georgia, you're pulling blood, doing vital signs.
Yeah.
Yeah.
I was wondering who do the baby shots, like they go do that.
Just the nurses.
Just the
Nurses
first
most of the
shot.
time. But it could be that the way they're switching out, the way they're trying, they're not rehiring LPNs. They're hiring CMAs to give medications. You can give everything, but anesthetics, analgesics, things like that. But you can give a shot. Yeah. Quality improvement methods. In order to reach improvement, we are doing quality improvement methods. All that is anywhere you work at, you're gonna have like a little quality control system. And what you need to know here is, what is a flow chart? What does it do? It breaks out components into diagrams in order to understand a process. Know that definition. Know that next definition. A Pareto chart. It's a bar chart to show frequency of problems. So what does it show? Frequency of problems. All kind of different things can be what may affect the quality of your technique, including the technique of the phlebotomist, the frequency of hematomas, and recollection rates. Recollection rates could be just because somebody's not labeling right. Somebody's shaking them too hard. Sometimes you let the stuff sit too much before it gets tested, and you have to go retest. So just make sure you want to get everything to the lab in 2 hours, if possible. If it says stat, you want to get it to it right then if you can. ASAP. When y'all do a stat, how quick is it that you need to take it?
It depends on what else we got to do. Like, if it's from the ER, we got to go get it ready. Unless the nurse is cool.
Yeah.
And if it's a cardiac or troponin.
You doing those? Oh yes, yeah.
Before 10 minutes.
That's hard to take. They're trying to figure out what's going on with them. Yeah.
Get a lot of those.
And in that case, the nurses should be pulling those.
They're supposed to, but I guess they.
Because, they're right there, they're there. Let's pull the blood.
Well, they tell us they don't want us to speak them until they start the IV. So
Right.
they try to get the IV started.
Yeah. I got you. You're right. And y'all will go through that as well. When we're gonna do that, when is the best time? Where do they like to go as opposed to where we like to go?
Exactly, because.
So sometimes they'll be like, please don't use that right there.
I need a smaller needle. I need the baby needle.
Yeah. Yeah. They're terrible. I'm telling you, but the phlebotomist is the expert. It's the expert. You should always be able to find your veins. CMAs is next up. You're going to be the expert where you're at. And then the nurse is told that they didn't even give us a day of class in phlebotomy. They assumed we watched the videos and we got it. That's how it was. They didn't show us none of that. Eventually, when I went back to RN, they actually had a little hand, so we could start IV on a hand. But everything else, pulling blood, we wasn't taught that. My first day on my job, but was the second job I had. That's the first thing they wanted me to do, draw blood. Okay, wait a minute. I really had not even ever draw any blood. But because I was told, I knew what to look and feel for, and I got it. And after that, once you get that and you get the process, you're fine. And you'll see. Once y'all start sticking, y'all get so comfortable, you'll be like, okay, just give me a good vein. That's all you want then. You're going to find them, but you just want the good one so you can get on with your day and go to the next one. So that's what quality improvement's made for, trying to make sure and try to fix the problems that are occurring. Then they have quality control records, should include and underline that expiration date, stability information, storage, proper use, precision, accuracy. All that is saying they're trying to pinpoint, like, if there are troubles or you're having to do a lot of redraws, what is it? Is it the equipment messing up? Is the patient, is the phlebotomist messing up? What's really happening? Your work environment, they're listed all kind of places: insurance companies, hospital, clinic, doctor's office, laboratory, blood bank, research firm, pharmaceutical firm. Goodness. Underline them last two. Researches are done to specialize in research. Pharmaceutical, they're developing meds and drugs and probably doing levels to make sure people stay within a certain level. Safety consideration. Pharmacy. I want y'all to be pharmacy techs so bad. Phlebotomy technicians must be aware of the risks and dangers involved in specimen collection. Know that there is an organization, CDC, Center for Disease Control, that is very much interested in y'all not trying to hurt yourself or somebody else or spreading blood or blood diseases. So we're going to wear our gloves. You do not pop that one little finger so you can feel. That's the feeding the purpose. A lot of people do it, and you'll see some nurses do it, and they try not to use that hand when they're drawing the blood, but it's just the purpose of why we have the gloves on in the first place. So make sure you keep your gloves on. Underline, universal precautions require that all used needles must be discarded intact. I don't know who's going to do whatever to the needle before they throw it away, but what they're saying is it needs don't do nothing to it. Normally they have like a little safety thing on it. If it doesn't have the safety thing on it, you go straight to your sharps container. If they don't have those safeties on it, and it really depends on where you're at. Some of these have safety, some of these don't. I think I'm down to my non-safety because I tried to put the safety ones out early. But safety. Although certain bodily fluids such as feces, urine, and blood can be a potential source of infection in a protective isolation setting, it is the phlebotomist who is the potential threat to the patient. Underline that. Who is the potential threat to the patient if they're in isolation? Yes. If they're in isolation, there's something wrong with their immune system. That means you are the danger to them. You need to protect you from them.
Can you read it again?
That one where it says, although certain bodily fluids, but in a protective isolation setting, you are the threat. Or anybody else coming in there with germs is the threat. And germs are really bacteria, so we say germs, but bacteria. Our common talk would be germs. The nurse talk, phlebotomy talk, bacteria. It is necessary to wear masks, gloves, and coats or gowns. Underline that. When those people who are in isolation, you need to go in there with all of that. They're in protective isolation. They are being protected from all the other germs. You're their danger. Also know that if somebody does catch an infection, which happens, they call it nosocomial. Underline that word. It's that last one in those group of sentences. If patient develops infections while in the hospital, we call it nosocomial. Underline as well the next sentence. The chain of infection usually includes the source, a susceptible host, and poor isolation technique. It's normally what happens. That's why an infection happens. The source, the host. So I'm the source, you're the host. I done gave it to you for poor isolation technique. Hygiene. Always wash your hands, especially if they're visibly dirty. Underline that said is hand washing is the single most important way to prevent the spread of infection. Equipment. You may have gloves, gowns, masks, goggles, gloves, gowns, coats. I said some of them over. But all of the above. A lot of times your phlebotomist will come with it's a little thin jacket. And that's to help not spread germs as well. But you'll have your little jacket on. And a lot of times that's how we know a phlebotomist. They'll wear their jacket. Autoclaves, underline. It's the instrument for sterilizing under pressure. And that's what it does. It's like a pressure machine, and it busts all the germs, all the bacteria, even spores, which are hard to kill. It kills that as well. That's why we're going to use an autoclave, especially for surgery. We do not want any germs, anything going on with that. You deal with autoclaves a lot. Yeah, that is your job. So, that is killing all the bacteria, everything that's with the autoclave. Emergency needle stick information. If exposed to blood due to a needle stick, what are you going to do? You're going to wash the needle stick and cut with soap and water. Flush your mouth, eye, skin, whatever needs flushing, whatever you done stuck needs flush. Then report it to the supervisor and go get medical treatment. Nowadays they've got something that you can take, like if you were exposed or possibly exposed HIV. That is some of those viral medications that is preventable. So make sure anytime you get a stick. One time I was so mad. I took out my friend's trash. I wasn't so sure about her brother. But I took her out and I got stuck. I was like, oh, what the stuck me out your trash bag? They were throwing their needles in the trash bag. They got children taking out their trash. They got everybody taking out their trash. And I just, because the trash was overfull, I said, let me take this out. Because I had some more trash put in it. But that's why I took it out. And got stuck. And I said, oh, Lord, help me, Jesus. Because I wasn't sure about the brother. I was not sure about a brother. He's recently passed. Not for that. He had, my girl family is a bad dialysis. And that's what he died of. But he was everybody's man. And it just scared me to death because he's diabetic too. And so all he needed, and I said, I'm going to kill you. But watch that. Protect other people. Don't be throwing needles in the wrong places. Even if, say, I give you a container and it's full, just use a bottle. Use something that's, something a little harder. It's not gonna go through it. A lot of diabetics would just throw their stuff in a bottle.
Coffee cans.
Yeah, coffee cans, those kind of things. That's a good one. Yeah, it's good as 30. But something other than just throwing it in a trash can. Don't do that. Any kind of needles do not go in the trash cans. You got everybody that's dealing with your trash, so don't do that. So know that as well. We got a vital sign chapter. We went over the vital signs, or we didn't get to the vital signs in the other one. But let me see how far this chapter goes. But I do want y'all to go ahead and read chapter 2. It's not, again, I'm going to tell you, it's not bad. These chapters are not bad. When it gets to the parts where you need to be learning, page, I can't see the page, but where it says arteries and it lists all them arteries, don't worry about them arteries. Don't be wasting your brain with that. Nor the veins. We're gonna label some big veins. Not even label them, but we talk about big veins, but not Not so much. You see all those pages? I want y'all to look through chapter 2.
You said we don't need to worry about arteries or veins?
Not remembering them, but some basic stuff we will, but not remembering where they're at, where they are, or label them.
The ones that reach out to.
Yes, and don't focus on the knowing all those veins, because what it is, most of your vein and artery work, depending on what it's supplying, that's how they name it. So if you get that in your head in the beginning, naming them is not so bad. But we're not even gonna go there. I need you to know everything about arteries and veins, but not the names of them and where they're at. If that makes any sense. So yes, know everything about arteries. Know your veins. Know all those paragraphs, but the list, don't worry about it. Does that help? Okay. The list, don't worry about it. All right. So don't forget your definitions in the back of your book. This is this one that you want a good copy of. We will get to that and know that. Then we're gonna look at these needles and see if anybody's ready to stick. And you actually, as far as you sticking, I can see one stick. You won't have to stick no more. With anybody. Did you find your sticks?
I didn't go home last night, so I'll be able to Thursday.
But don't forget that. If a patient develops an infection while in the hospital, what we call it? Nosocomio. I like that word. Nosocomio. What is a Pareto chart used for? Get in your book. Flip through the page. Frequency of problems. Bar chart for frequency of problems. If blood is collected for testing drug levels, the primary consultant for timing guidelines is whom? Pharmacy. If it's drug levels, the consultant will be pharmacy. They're going to tell you when they, prescribe their meds. A type and blank process takes place for transfusions to determine if a patient will react after a transfusion. Type and cross match. And, says and, blank, is an instrument used for sterilizing equipment under pressure. Okay, so you got that one. The process of collecting a blood specimen for laboratory testing is known as. The process of collecting a blood specimen for laboratory testing. Y'all in this class. God bless. Venipuncture would be the other word we would use as well. But phlebotomy. If blood is collected for, expiration date should be included in, I told y'all that underline it. Yes, quality control. Universal precautions require that all used needles must be discarded. In sharps. Another word, straight out the book. How you gonna put them in the container?
Gotta close up the needle.
There's a word.
You never kept
Universal precautions require that all used needles must be discarded. Intact. All of that y'all said is correct, but it needs to be intact. Good hand hygiene techniques reduce the number of infections, pathogens, bacteria. All those things will go there. If a patient develops an infection in the hospital, what do we call it? A blank is an institution that develops and markets drugs for the use of medications. Pharmaceutical firm.
So would that be on Tuesdays too?